Thank you. Good evening, everyone. On behalf of Department of Pediatric Orthopedics KGMU, we welcome everyone for today's webinar. This is sixth webinar in the lecture series of pediatric trauma on the Friday Musings series of UPOA and KGMU. And I welcome all the learned speakers and thank them for their effort and time for this webinar. And I welcome all the attendees. Also, it is our we are fortunate that President UPOA, Dr. Sanjay Dhawan is with us, and I request her to say a few words for this today's webinar. Over to you, sir.
Thank you, Suresh. A very good evening to one and all present here. And I welcome you all to this Friday series of webinar on pediatric orthopedics organized by KGMU Department of Pediatric Orthopedics, headed by Dr. Ajay Singh. And I congratulate him and his team for continuously coming up with this pediatric trauma series, which I'm sure that is everyone who's attending it is getting benefited. And I also thank the faculties present here today, Dr. Arun Gupta, Dr. Abhishek, and Dr. Raman, our good friend, spending time and enlightening us with their wisdom. So without wasting much of your time, I would like to move on to the academics. Over to Suresh. Thank you and welcome again.
Thank you so much, sir. And now I request Professor Ajay Singh, sir, Head Department of Pediatric Orthopedics KGMU and President, Pediatric Orthopedic Society of Uttar Pradesh, to formally welcome all the speakers and attendees and start the session. Over to you, Ajay Singh, sir.
Thank you, Suresh. On the behalf of Uttar Pradesh Orthopedic Association and the presence of our President, Dr. Sanjay Dhawan, and from my team from Department of Pediatric Orthopedic KGMU, I welcome once again to all the delegates and my esteemed speakers, as well as the OrthoTV team, who are everyone is there just to improve the sensitization of injuries by a series of webinars which we are conducting every month. And the purpose of this series is to gain the interest in young orthopedic surgeons about this new super specialty. I would like to share that the Pediatric Orthopedic Society of UP, that is POSUP, has just started its membership drive, and within 48 hours we are able to make 62 life members and 23 associate member in just a span of 48 hours. So it is this shows how much interest is there in our friends, young, especially the young orthopedic surgeons. So I wish everyone a very nice session on pediatric sports injury. Over to Suresh.
Thank you so much, sir. As I noticed, Dr. Anup has joined. Good evening, sir. A few words from your side, sir.
Good evening, Suresh. Thank you for calling me. I welcome all the speakers and congratulate the Department of Pediatric Orthopedics for continuing this webinar. I'm sure and very sure about this, that this will continue further, and the members not only across UP, all across India will keep on learning the intricacies of pediatric orthopedics. Thank you, Suresh and Dr. Ajay Singh for inviting me. Thank you.
Welcome, Anup. Anup, you are here despite of your ill health. It means a lot to us. Thank you.
Thank you. Thank you, boss. Thank you.
Suresh.
Thank you so much, sir. Thank you so much for all the kind words. And I once again welcome all the attendees who have joined now. And we are happy to announce that we are live on Zoom as well as YouTube and OrthoTV platform. And these all three will give access to a large audience. And I request to post their question in the chat box or WhatsApp to me at 8826533834. A question and answer session will be taken at the end of session, and all the speakers will will be happy to answer at the end of session. And without much ado, I welcome today's first speaker, Dr. Abhishek Saini, who is Assistant Professor in Department of Sports Medicine in the King George's Medical University. He has done his FNB in Sports Injury from the Sports Injury Center, Safdarjung Hospital, New Delhi. And he'll be giving his talk on today's first topic. Over to you, Abhishek.
Hello, good evening, everyone. My screen visible?
Yes.
Right. Thank you, Ajay sir, for giving us this platform to discuss the very important topic of today's scenario, which is pediatric sports injuries. The pediatric sports in India is in a very beginning stage compared to our Western counterpart. So it's very important for us to discuss this because a lot of kids nowadays are going into sports. Just hang on, the slide is not moving. Yeah, so you can see a picture on your screen. So this picture sums up literally everything about pediatric sports. I'll discuss about this picture in the end. So the outline of today's talk would be to discuss the risk and benefits of youth sports participation, the epidemiology, the exceptionality of young athlete, to identify different overuse injuries, and the most important of all, the prevention strategy. So first of all, a very big question is, now a lot of kids are playing at different level. So because of that, they are now more prone to injuries, right? So the question is, should we stop our kids from playing? So I was going through the literature, and I came upon this paper, which was published by American College of Sports Medicine in 2018. So they come up with this pediatric inactivity triad, which is a triad of exercise deficit, a physical illiteracy, and pediatric dynapnea, which is decrease in the muscle strength. So they found out that almost 60% kids in USA, they were suffering from this triad. So actually, we don't want our kids to be suffering from this. So the benefits of youth sports. So the thing is, it's a fun activity. It helps in developing our self-esteem. It helps kids, to socialize with their peer. And then it increases the teamwork, and on a longer run, it helps in developing the leadership qualities. But there's a fine line. Now, with a lot of competition coming in, there's a lot of pressure from coaches, from teachers, from parents for increased activities at younger age. And this leads to what we'll be knowing about pediatric sport injuries. Now, a lot of studies have been done in the Western world about all the pediatric sport injuries. We don't have any data from our subcontinent. So all the data which I'll be quoting will be from the Western world. So according to this study in USA, there are almost 60 million kids who are playing organized sports. And of them, more than 44 million are playing more than one sports in a year. And the injuries, they have increased from 10.8% to 12.4% to 2015. All this data is from USA. We don't have any data from Indian subcontinent. And talking about high school athletes, almost 2 million kids are getting injured. Of those, 1/4 of them are visiting the physicians, and half of them are having overuse injuries. So according to CDC, more than half of the injuries are preventable. And there are 30,000 hospitalizations, and of these, 21 are having traumatic brain injuries. So the reason for more of traumatic brain injuries in those kids are because they are more into rugby, baseball, and basketball. Now, this study in 2014, that's shown that the acute injuries, depends upon which kind of sports you are playing. So if you're playing a team sport, the incidence of sprain and strain is more, whereas if you're playing individual sports, the sprain, strain, and fractures are almost equivalent. Statuliani et al. Have done a lot of research work on pediatric sports injuries. So they have compared about children of the age group of 5 to 12 and adolescents from the age group of 13 to 17. So they found out that the fractures were more in the younger age group, whereas the older age group had a equivalent proportion of all other injuries. In another paper of theirs, they differentiated between male and female injuries. So the fractures were more common in the male counterpart, whereas the female counterpart had more of patellofemoral pain injuries. Now, why do we need to study young separately? Because they have different body composition, which leads to more injuries. Now, children, they are not miniature adults. As we grow, the head to body ratio decreases. So in the initial 2 to 5 years of age, the head to body ratio is more, which predisposes the kids to more injuries. Also, they have decrease in neuromuscular control, and also the lever arm of the arm and the legs are more, which leads to more injuries. Then they have a growth spurt, which between the 12 to 14 years of age makes the kid more prone to growth plate injuries. And this is the most neglected part. So the kids, they usually generate more of heat and they dissipate way less heat. And this leads to dehydration and fatigue. So this needs to be taken care of. Now, coming to sport injuries, they can be age-specific, sports-specific. They can be acute, overuse, or site-specific. So most of the acute injuries are usually traumatic injuries, which have been dealt in the previous. We won't be discussing all this. So the overview, we have overuse injuries, then lower extremity injuries, upper extremity injuries, back pain, and potentially serious injuries. So the overuse injuries, these are the risk factors. We have intrinsic risk factors and extrinsic risk factors. So we can easily control the extrinsic risk factors, taking care of the environment, the equipment, how we train the kids. And the intrinsic risk factors are usually taken care of pre-participation level, which helps in kids in prevention of their injuries on a longer term. Now, coming to overuse injuries, now they can be apophysitis. We have, the apophysis is the secondary ossification center. So at the age of when there's growth spurt, they're bound to have more of injuries related to different apophysis. And we all know that the different eponyms which we have studied throughout our academic career. Then we have the bone stress injuries. We can have it either high risk or low risk. So the high risk are the ones which lead to loss of time from sports and might also threaten the future participation of the kid. So depending upon different location, we have high risk and low risk. We won't go into details because we have upcoming lectures on this particular topic. Now, this is very important. We have catastrophic injuries. The most common cause of non-traumatic death is cardiovascular, which is hypertrophic cardiomyopathy. And in cases of traumatic, it is more because of head and neck injuries. So the kid which you are seeing in this slide, he was 11 years old when he suffered cardiac arrest while playing football. And he was playing for the club of Arsenal under 13. So it's very important that before playing, everybody is screened for cardiovascular system. So it is always told that, if you work more, it's better, but it's not. So when the workload increases, the level of fitness decreases. So now there are some risk factors, related to sports which might cause overuse injuries. So if you are specializing in particular sport at a very younger age, you are more bound to have injuries. So this is a burning topic in the Western world as of now, whether to put our kids, at a younger age in a particular sports or not. And if you're playing for more than 5 to 6 days a week, it leads to increased risk. Similarly, if the playing hours are more, that is a risk factor. And also, telling your kid to play through pain, it's a very big risk factor. We need to stop that. So as our role, in all these injuries is to identify high-risk injuries, to treat acute and chronic injuries appropriately, and we are the main mediators between parents and the athlete, and need to educate, all the coaches, the trainers, therapists on how to prevent our injuries. So prevention is the best modality in these sports injuries. Now, if we come to key assessment, we need to know the age of the kid. Is the kid having the growth spurt at that point of time or not? Whether the pain is chronic, the duration and frequency of pain, the severity of pain, and the location of pain. It also need to ask the patient that has there been a recent change in the training volume or intensity, because all of a sudden he can come up with pain. There can be change in the performance. There can be decline in performance, and it's very important to ask female athletes if they are having any symptoms of amenorrhea. We'll discuss upon that later on. Coming to prevention, as rightly said by Benjamin Franklin, an ounce of prevention is worth a pound of cure. So it's not only the child or the parent which has to do all the prevention activities. We as a nation, as a government, everybody should be involved at different levels to help educate and prevent the sports injuries. Now, if we know the developmental level of each kid, no, it's better, then it would be better for us to put a child into a particular play. So we know that a kid of aged from 2 to 5 years of age, he is not fully developed. He has limited fundamental skills, fundamental balance skills are very less, and the vision is not fully mature. So it's best that they do running, swimming, throwing activities. As they grow, their fundamental skills improve, their vision improves, the learning attention span improves. So we can, make the kid play entry level soccer or a baseball. Now, as the kid grows into the age of 10 to 12, it's almost, the vision is almost like an adult. The motor skills improve, the learning is very much improved. So they can play sports like basketball, which is a bit complex compared to other sports. So talking about prevention, it's very important to have a pre-participation examination of the kid. So in Western world, they have a whole format where they'll screen the whole kid through from head to toe, about every organ and system. And we need to make sure that they have adequate rest. We should avoid overscheduling the training. We should monitor the training, especially during the adolescent growth spurt. And there are different things we need to take care of: the equipments, the training ground, how the mode of training is done. And most important is the return to play. Now, if the patient feels that he's okay, that is not equally, and is not equally healed, is equally good. Progression should be pain-free range of motion. Functional drills, endurance, and agility testing should be done by the sports physician. And sport-specific skills should be done before the patient plays his natural sport. Now, what can parents do? They can ask their kids to play a variety of sports when they are young. You should wait till the age of 15 to 16 before they specialize in a sport. You should allow kids to train less than their age per week. You should think, why your kid or you want him to specialize, and keep an eye on your kid's health, because that's very important, especially the teen girls. So this was a strategy of American College of Sports Medicine, where they say that you should avoid sports specialization, limit the training to 18 to 20 hours per week, limit practice for 1.5 hours and half hours or 4.5 hours per week, depending upon your game. Focus more on intensity. And young athletes should take a week off every month. Now, coming to the female athlete pride, now this is very important. We all know that we all studied about female athlete pride, which is menstrual disturbance, low bone mineral density, low energy availability. So the kids who are playing, they are more prone to female athlete prides. It was usually more common in gymnasts, in ballet dancers. But this term has now been replaced with the REDS, which is relative energy deficiency in sports. So it is basically deficiency in the calorie, which leads to loss of muscle strength, loss of carbohydrate storage, which all leads to increased injury risk. So it was found both in male and female athletes at a younger age. So this term is now used instead of female athlete pride. Now, this take-home message is that it's a multidisciplinary approach. So everybody, right from the whole community, needs to take part in this prevention of sports injuries in pediatric age group. Proper history taking is the key, and we all know that prevention is better than cure. Thank you. Now, coming to this picture, these three kids, they were the youngest medal winners at Olympics. The girl who won this gold medal, she was 13 years of age. On her right, she won silver. She was 12 years of age. Both were from Japan. And the girl who won bronze, she was from Britain. She also was 12 years of age. So age is just a number. So we need to decide upon where is the limit to sports. Thank you.
Thank you so much, Dr. Abhishek. That was excellent talk and well within the time limit of 15 minutes. And I request all the attendees to kindly post their questions or queries in the chat box. We'll discuss them in a question and answer session. And after this, we'll move on to our next speaker for the day, Dr. Arun Gupta, sir. He is head of the Department of Orthopedics at Pushpanjali Hospital, Agra. He has done his fellowship and further work in sports injury at the KMC Manipal. I welcome Dr. Arun, sir, and over to you, sir.
Good evening, everyone. Am I audible?
Hello.
Yes.
Yes, sir.
So at the outset, I would like to thank UPOA and Department of Pediatric Orthopedics, KGMU. The topic given to me is stress fractures, avulsion, tendinopathies in teenagers. It's a huge topic. Probably it requires a separate symposium for all these factors. I'll try to justify my talk. And coming to stress fractures, what is a stress fracture? These stress fractures occurs through otherwise normal bone that is subjected to repeated episodes of stress, less severe than necessary to produce an acute fracture. It results from summation of stresses, any one of which by itself would have been harmless alone. The epidemiology has been taken in detail by the previous speaker, Dr. Saini. It is common in athletes and teenagers preparing for military services, and increasing participation in sports in last decade has witnessed an increase in incidence in young children or athletes. Stress fracture at pediatric population are more liable to be mistaken, and hence they are more important to decipher because they are mistaken at times as neoplasm or infection because of rapid periosteal response and abundant callus formation. The outline we will discuss about pathophysiology, risk factor association, diagnosis, general treatment, and few specific cases. The cause is simply a change in load on the bone. So there could be small number of repetition with large load, or large number of repetition with normal load. Or there could be an intermediate combination of increased load and repetition, which can lead to bone fatigue. So as we all know as an orthopedic surgeon, that bone follows the Wolff's law. Change in external stress leads to change in shape and strength of bone, and bone remodels in response to stress. So if there is abrupt increase in duration, intensity, or frequency without adequate rest, that is no chance of remodeling, it can lead to stress fracture. And that is imbalance between bone resorption and new bone formation, which will lead to microfracture. And if the load is continued, will lead to ultimately a stress fracture. So it is about 1% in general population, and it about up to 8% in collegiate team sports. It is as high as about 31% in military recruits, and the gold medalist among this is about 50% in runners. And we see that with the advent of so many highways or expressways in all over the country, the rural kids have got the space to run about, and they develop so many stress fractures in their lower limbs. So coming to the risk factors, so there could be a history of prior stress fracture, which can lead to further stress fracture. Low level of physical fitness, that is prior non-athlete. Increasing volume and intensity of that particular exercise. Female gender, as discussed with Dr. Saini. Menstrual irregularity. Diet poor in calcium and protein. Poor bone health and poor biomechanics. They all contribute to development of risk stress fractures. So the what is the prior stress fractures? There are about 6%, 6 times increased risk in distance runner and military recruits. 60% of athletes have history of prior stress fractures, and there is a 1 year recurrence in about 12 to 13% of these kind of people. Poor physical fitness, because if somebody has got a less muscle mass, that these muscle will absorb the physical impact. So more than 1 centimeter in calf girth can lead to tibial stress fracture. Less lean mass in lower extremity will lead to stress fractures, and less than 7 months prior strength training is required. Suddenly the date is announced for a military recruitment, a police recruitment, the kids start running. Within a span of 15 days, they develop a stress fracture. So that is the risk factor. There are intrinsic factors such as anatomical factors, extreme arch morphologies such as pes cavus or pes planus. The biomechanical factors also contribute to it. The shorter duration of foot pronation, subtalar joint poor control, tibial striking torque when the kid doesn't know how to run properly, early hindfoot eversion. These are all things which has to be taken care of while we are looking into the etiology of stress fractures. Extrinsic factors like activity type and intensity, footwear. Some people doesn't have the proper shoes. They should use the shock absorbing cushion inserts. And the running surface in urban area is the treadmill, and in the rural area they are running on the concrete roads, which can lead to a development of stress fractures. Associations, especially with the type of sports like ballet dancing or Bharatnatyam sort of dancing, where hyperextension of the lumbar spine is required, they can lead to lumbar spine, femur metatarsal, runners usually tibia metatarsal, sprinters navicular bone, long distance runners, they have a propensity of femoral neck or pelvis fractures, baseball, tennis, humerus fracture, gymnast, spine, foot, pelvis, golfers, ribs, hurdlers, patella, rowers and aerobics, sacrum, bowing and running will lead to pelvic stress fractures. The classical clinical history is that there is a change in training or equipment, gradual onset over 2 to 4 weeks, initially pain only with activity and progresses to pain after activity. Eventually, constant pain with activities of daily living is the presenting feature, and the history is itself shows everything about that. There is a history of sports participation, significant change in training, that suddenly they have gone to hills and they are running uphill. The surface has changed, the intensity has changed. The dietary history about inadequate vitamin D and calcium, loss of periods in young girls, general health, the occupation, some medical history, medication, especially for some arthritis or self-medication with steroids, or the family history of osteoporosis, all they can lead to osteoporosis. The investigation, the preliminary investigation is usually a plain X-ray. And remember, only 30% positive on initial X-ray examination, 10 to 20% never show up on plain films. If it is positive on X-ray, there will be a localized periosteal reaction, or it could be a radiolucent line. And in cancellous bone, remember, there could be a band-like focal sclerosis, which is a telltale sign of a stress fracture. So here is a case, if you see in this particular X-ray, it can be passed as normal when the young athlete came with a foot pain after running, and after 1 week we can see that there is a fracture in the third metatarsal shaft, which has become evident in the third week of the presentation. So bone scan is the most sensitive investigation, with 95% show up after 1 day. Extremely sensitive, but remember, not as specific, with up to 24% false positive results. It can differentiate between acute and old lesions. Acute stress fracture is 3-phase positive, and shin splint type of injury can be delayed, it can be captured in delayed phase only. MRI versus bone scan. The MRI is less invasive, readily available across all the towns where the bone scan is not easily available, provided more information than bone scan, and recommended for initial diagnosis and staging of stress injuries. Limited MRI may be cheaper than bone scan at most of the institutions. How you decide whether to ask for MRI or bone scan? MRI usually can be done more quickly. It usually takes 40-50 minutes as compared to 4 hours in a bone scan, and is scheduled for a sooner date. There is no radiation hazard and has a better soft tissue detail. Whereas bone scan covers a wider area of body if bilateral or diffuse symptoms are there. Sometimes easier to interpret, because at times we are not, the patient is not able to tell us the exact site of pain, then the stress fracture, then the bone scan is better. And at times the bone scan is cheaper in some government institute. So the general treatment of the stress fracture is to protect, reduce pain, promote healing, prevent further bone damage. Activities of daily living are permitted. Continue with stretching and flexibility exercises. Cross-training, that is non-weight-bearing exercises, can be continued. There has to be a modified rest for 6 to 8 weeks or until pain-free for 2 to 3 weeks. Then only they are allowed to do their sporting activity or running activity. The activity modification means that particular activity should be pain-free and is away from that affected limb. The approximate desired activity can be like cycling, swimming, leisure walking, elliptical trainer, deep water running, and remember, any one of these activities, once we advocate, must be pain-free. The rehabilitation exercise will address the biomechanical issue like muscle rigidity, limb length discrepancy, excessive pronation, pes cavus, pes planus, replace the running shoe, and the strength training by various modules. The sites of stress fractures have been studied in detail, and the commonest one is the tibia, which we see almost in our OPDs. It's about 40%, then metatarsal 21%, fibula and pelvis about 2%. So the high risk one, the bones are depending on the type of sports, like pars interarticularis of the spine, femoral head, neck, patella, anterior cortex of tibia, that is the tension side, and the smaller bones like talus, tarsal navicular bone, proximal fifth metatarsal, sesamoid of great toe, base of second metatarsal, and at times medial malleolus. So anterior and middle third stress fracture of the tibia are very concerning. They are usually tension side of the bone and they are very painful, may present like shin splints. It becomes the anterior tibia is swollen, hard, and more commonly seen in jumpers and leapers. You can see a dreaded black line on X-ray, and they heal very poorly and take a lot of time to heal. You can see a small crack in the anterior cortex of the tibia. It's a dreaded black line. The treatment is to immobilize for at least 4 to 6 weeks, and at times the athlete or the runner or the sprinter, they don't take your advice and they culminate into a complete fracture. And at that point of time, the intramedullary rod may be required to fix the fracture. The fifth metatarsal stress fracture is different from a avulsion fracture and a Jones fracture. So if you see that the stress fracture is more at metaphysiodiaphyseal junction, and it is important because it has got a higher risk of delayed union or non-union as compared to Jones and avulsion fracture. Non-weight bearing cast for 6 weeks is required. And if you see there is slightest of displacement and disobedience from the patient side, we should advocate intramedullary screw fixation in a patient. The femoral stress fractures are primarily presenting symptoms of groin pain, possibly in thigh or knee, at times difficult to identify, and then bone scan is required or MRI is required. Hip motion may be painful, and hop test, patient is not able to hop, is required. Fulcrum test for shaft femur fracture is at times positive. The femoral neck stress fracture, early diagnosis is very critical. If X-ray is negative, bone scan or MRI has to be ordered. The MRI diagnostic is a diagnostic imaging of choice for femoral neck stress fractures. So there could be of two types, like compression side, that is on the medial aspect of that inferior part of the femoral neck. They are rather in younger patients and less likely to become displaced because of the forces on that. And complications are possible if neglected. Treatment is usually non-weight bearing, followed by toe touch weight bearing, and then partial weight bearing over a period of 8 to 12 weeks. Usually they heal uneventfully. And on the contrary, the stress fractures on the distraction side, that is on the superior side, the tension side of the neck, they have high propensity to become displaced and can lead to frequent complications. They should be treated if you see a complete fracture line even on MRI with aggressive internal fixation. And coming to tarsal bones, they are more in sprinters, jumpers, and the mean interval to diagnose is about 12 months before they could be diagnosed because of the poor picturization of the tarsal bone, and there could be a vague midfoot pain in the dorsum of foot. At times they present with simple cramps which are usually ignored. And so there is usually an end spot for the navicular fracture, which is tender to palpation when a patient has a navicular stress fracture. When you see, you have to palpate it here. That is, this is the avascular central 1/3 of the navicular. The bone scan can depict and pick it up at very early stage, and MRI or CT scan can catch it at the inception of the fracture. So more studies suggest that allowance of weight bearing immediately after diagnosis can increase the non-union rate in this navicular bone fracture. The simple rule is the bone scan MRI or at the early stage to diagnose the fracture, and then non-weight bearing cast for 6 to 8 weeks and then gradual rehab. If the fracture is complete, then open reduction internal fixation with compression screw with or without bone grafting may be required. The high-risk fracture sites, as we have discussed, that femoral neck, tension side, navicular, fifth metatarsal, anterior tibial shaft, and they are high-level athlete and laborer, and they can fail to conservative therapy. The prevention has to be advocated to all patients that some small incremental increases in training is required. Shock absorbing shoe and boot inserts, calcium and vitamin supplementation, significant increase in bone mineral density, no impact on stress fracture rate. Modification of female recruit training has to be advocated, that lower march speed to run on softer surface, individual step length and speed, interval training instead of continuous training, which has been advocated by American Academy as well. So the take-home points are: avoid a delay in diagnosis, do imaging diagnostic test early in the symptomatic period. Remember, rest is only a 4-letter word to these kids and athletes because they are very hyperactive, and as soon as some amount of pain is less, they will again go to play. So thus advise a relative rest, allowing for various kind of cross training to satisfy their energy on the unaffected body training part so that the affected part heals fast. Correct underlying nutritional, hormonal, or biomechanical abnormalities to promote healing and prevent recurrence. Despite our best efforts, some athletes will never return to their pre-injury level of competition due to some specific stress fractures like navicular, femoral neck, and anterior tibia. So counsel them properly. Coming to avulsions and tendinopathies, the second part of this talk, that the avulsion injuries or a fracture occur where the joint capsule, ligament, tendon, or muscle attachment site is pulled off from the bone, usually taking a fragment of cortical bone. Avulsion injuries results from application of tensile force to the musculoskeletal unit or a ligament, and avulsion fractures are commonly... Hello?
Sir, the amount of time allotted is over. If this is too long, we can accommodate in some other webinar also.
Yeah. Can I sum it fast?
Yeah, sure. So
avulsion fractures are commonly distracted due to high tensile forces involved. And remember, the most common site of avulsion injuries in the adolescent and children are apophysis of pelvis and knee. There are two distinct kinds of avulsion, acute and chronic. So acute occurs because of sudden forceful injury, whereas there is a clear history in most of the cases. In contrast, chronic injuries are due to repeated submaximal forces. And these are the basic vulnerable apophyseal avulsion sites depicted in this long slides. So coming to the pelvic and femoral avulsion injuries, which are more common, they are divided into two groups. The most common injury mechanism is abrupt, strong, and concentric and eccentric contraction of large muscle that occurs during an attempt to accelerate or decelerate the body mass, such as the split, or you see the cheerleaders which are splitting in the various games. They are usually the young girls in their late teens. The apophyseal avulsion injuries of the hip and pelvis usually occur in the adolescent athletes and can go till their mid-20s. Remember, the apophyseal physis usually fuses later than the physis of long bone. In the largest study by Rossi and Dragoni, they find that the maximum number of apophyseal avulsions are near the ischial tuberosity. The ischial tuberosity is the insertion side of very strong adductor muscles, and you see here in a case of about 16-year-old taekwondo player, a flake of bone has been avulsed in a flying kick, which is rather more easily picked up on an MRI. The ultrasound, CT, and MRI are more useful than plain X-ray to find out these avulsion injuries. And MRI is the most accurate imaging tool for diagnosis, especially for identifying these kind of injuries. The treatment for avulsion injuries, if they are less than 1.5 millimeter apart, they respond to conservative treatment. At times, if they are displaced more than 2 centimeters, they need to be fixed. The another common site is anterior superior iliac spine and anterior inferior iliac spine, which are again in a sudden burst of energy, like in a gymnast, you see in this CT scan and X-ray. And again, the same principle of 2 centimeter is used to treat these kind of injuries. The knee is the third most common site for these sort of avulsion injuries. And we know a very common thing, that is C-gone fracture, usually associated with the lateral side of tibia, in which the capsular injury is also there, often associated with ACL injury as well. The ACL avulsion of tibial eminence is quite common, and this has been taken in detail by the next speaker. Summary: although diverse, the avulsion injuries occur in all age groups. They primarily affect skeletally immature athlete. These injuries can mimic more serious conditions such as infection or neoplasm because of the variety of imaging findings associated at different stages of mechanism. Thank you very much.
Thank you so much, sir. That was excellent talk on such a vast topic, and we are thankful that you have covered all of these issues in a short lecture. And we are again announcing that the current webinar is live on Zoom as well as YouTube and OrthoTV, and currently more than 50 delegates are attending this thing. And we welcome all the delegates who have joined later, and they can post their questions on the chat box, and we'll take up the question in the question and answer session. And now I request Dr. Rajeev Raman sir, the next speaker, who is consultant in the MRI Hospital, Kolkata, and he is well-known speaker all around India. And he'll be presenting the final talk for today. Over to you, Dr. Rajeev sir.
Thank you, Suresh, and thanks to UPOA and KGMU for invitation. So I will be talking on ACL injuries in pediatric knee, a very common injury now we see on our day-to-day practice because of increasing at a number of sports person who are participating in sports. And why this topic is important, because I think this quotation I have taken with my pediatric orthopedic friends only. Children are not small adults. You should have a different plan, and you have a different planning for them, because it's not like that. The way we treat the ACL injuries in adult, we should treat them in the same way in children. And what is difference in pediatric and adolescent ACL injury? If you see the incidence, the numbers are not quite less. It's almost 0.5 to 3% of all ACL injury. And the most common age group is between 8 to 12 years or sometimes 13 years of age. And there is still a debate whether what should be the operating timing, what are the repair technique, whether you should go for a conservative treatment or a operative treatment. So treatment options, yes, we have different treatment options. Conservative, it has been the treatment of choice for decades, and we have been treating most of the ACL injuries conservatively, even in our residency days. And nowadays, if you ask me what are the ideal cases for conservative treatment, is the partial ACL tear, because in children and adolescents, the chances of healing of ACL is more. So most of this partial ACL tear, if the patient is asymptomatic, yes, go for conservative treatment. Yes, operative treatment. Now, in athletic population and a sports person, I think it's the treatment of choice. And all children with the symptomatic knee, Suppose the patient is having a history of giving way, the patient is having the history of instability. In those patients, those symptomatic patients, try to treat them operatively. So timing, $1 billion question when you operate, either it's early or delayed. And there's a difference of opinion not only in orthopedic surgeon, but in sports surgeon also, whether we should wait or we should treat them immediately. Immediately, it's not been day one, whether we should treat them within 5 or 6 weeks of injury, before the closure of 5 weeks. So early is you plan your treatment immediately within 4 to 6 weeks, and delayed is you wait till the closure of the 5 weeks. What is the advantage of early treatment? We can prevent this secondary damage to the menisci and other ligament and cartilage if we treat this symptomatic patient early. And what is the advantage of delayed treatment? You can treat them like an adult patient. Suppose your patient is having a ACL injury at 13 years of age and he is ready to go with lifestyle modification for 1 or 2 more years. At 15 years of age, once the physis has closed, you can treat them like adult patients only. But my dear friend, most of this sport person, suppose you get an ACL injury in 8 or 9 year old children or 11-year-old adolescent boy, and in those patients, if you wait for them for 2 or 3 years, so that when the physis will fuse, you will plan for your ACL reconstruction, and it will be too late for him because he has to stop his sports activity, he has to stop his training program, and if he is a sports person, I think that will be a career-ending sports injury for him. Regarding technique, there have been different technique described in literature. You go through the Campbell, you have a physial sparing technique, that was the intra-articular technique, the transphysial or over-the-top technique, the partial transphysial technique, and now I think if you ask me what is the gold standard, I think it's the physial sparing technique where you can do intra-articular ACL reconstruction, avoiding injury to the physis. And that is, I think, the standard treatment protocol we follow in our day-to-day practice. Extra-articular process, I think now it's out of date. None of the sports surgeon or none of the pediatric surgeons are doing it nowadays because it's non-anatomical. So most of us are now doing a physial sparing ACL reconstruction in those patients. So why it is gold standard? Because it's anatomical and it will give a native ACL, almost near normal ACL to that pediatric or adolescent knee. So this is a small video technique of physial sparing ACL reconstruction. You can see here, this is a gymnastic player. He was a gymnastic player of Bangladesh. You can see he is having a typical anteromedial instability. The pivot is positive. The latchman is positive. So normally, we take a CMT graft in this patient, in pediatric patients. You harvest it from the medial aspect of the proximal tibia and try to remove the adhesions. And normally, because these knees are very small knees, so you can have a quadruple graft of 7.5 or 8 millimeters is good enough for those pediatric knee. So once you have harvested the graft, you can see, and I keep the needle there because I want to suture it with the periosteum at the end of the procedure. And once you put your scope inside, you can see there's a thin ACL, a bundle of a rim of ACL is there because this patient was symptomatic. So try to clear the remnant first because that is the anatomical point where you want to insert your ACL. And here, always take use of CR. Under image intensifier, what I do using my PCL jig, I pass my Bipin from outside in technique. You can see, and you can see in the CM that yes, it's not crossing the physis, where thus sparing the physis. So once you have done it, you can see here. So with this PCL jig, I am trying to make my femoral tunnel from outside in technique. So at every step, and now pass your suture loop through the femoral tunnel. It's almost same as adult ACL reconstruction. The only good thing is that you have to take help of CM so that you are not damaging the physis. In the same way, you take your point over the tibial entry also and put it over the anatomical point, and now you pass your loop from the femur to the tibia. You can see, and once you have passed it, what is important? Fixation at the femoral side. Normally what happens, because the tunnel is very small, you can't put an endobutton loop here. So almost normally we use a metal or a bio screw over that because it's a physial spring. You can put that screw over the femoral tunnel. And once you have fixed it, the second part is fixation over the tibial side. Normally don't use a screw on the tibial side or try to use a post at least 5 to 6 centimeter below the tibial joint line, so that you are not damaging the tibial physis. And you can see here, once you have fixed it, now the most important part is I have kept that needle there. You can see that needle part is there. So we try to give some amount of 2 or 3 whip stitches through the periosteum with the remnant part of ACL. You can see a robust ACL reconstruction has been done, and the latchman at the end of it, there is no anterior translation of the tibia. So yesterday only I asked him to say the video. Now he is 14 years, 3 years follow-up. You can see this player, and he is practicing in Bangbandhu Stadium, Bangladesh. So what is important in pediatric age group? Whenever you see this skeletally immature patient, normally you get a total ACL tear or a partial ACL tear or an incomplete ACL tear. So most of the time, if you are dealing with a patient in pediatric age group or adult soldiers with partial ACL tear, it's the important goal is rehabilitation. And the golden rule of rehabilitation is try to keep them on regular follow-up, try to strengthen the hamstring more than the quadriceps. Why it is important? Because hamstring is agonist of ACL. It's the agonist muscle of ACL. So what the standard practice of an orthopedic surgeon is, most of the time, with every ACL injury, we ask them to do a quadriceps. Quadriceps is agonist of PCL. So don't try to put this patient on quadriceps strengthening. Try to put this patient on hamstring strengthening, because we want to strengthen the agonist muscle. And that is important part. Suppose you have exercise program of 10 minutes. So 6 minutes should be for hamstring and 4 minutes should be for quadriceps. It should be always more than your quadriceps strengthening or quadriceps rehab program. So most of this incomplete tear, try to treat them conservatively. If you are dealing with a complete tear, some of the patient may have a complete ACL tear. So again, you divide it with 3 age group. Tanner stage 1 or 2, that is male less than 12 or female less than 11 years. Always go for a physial sparing ACL reconstruction. Believe me, that is the gold standard, where you don't damage the physis and you are creating an anatomic ACL, which will be a long-lasting anatomical ACL reconstruction. Second group of patient is Tanner stage 3 or 4, where your male patient less than 13 years and female patient less than 12 to 14 years. Again, here you can plan for a transphysial ACL reconstruction. But always use a soft tissue graft. One graft is contraindicated in pediatric age group and adolescent age group is your bone patellar tendon graft. Never try to put the bone patellar tendon graft in adolescent age group because of formation of the physial scar, and that may lead to a deformity in the proximal tibia or a distal femur. And the third group of patient is Tanner 5. You are male more than 16 years and female more than 14 years of age group. And you don't have to bother in such type of patient. You can plan your standard ACL reconstruction like you do it in adult. That is a normal femoral turner, normal tibial turner over the anatomical location. So that is the standard practice we follow in our day-to-day practice. Partial tear, try to treat them, rehab them conservatively. The hamstring rehabilitation should be more than the quadriceps. Complete tear, according to age group, plan either physial sparing, transepiphyseal, or ACL reconstruction as like adult in adolescent group, where male patient more than 60 years, female patient is more than 14 years. This is the standard treatment protocol for the ACL injury. And aversion injury, actually, I didn't prepare for aversion injury because I thought Dr. Arun will be speaking on that. If you want, I can show you a video of aversion injury. But I think if you want, we can go for discussion with ACL injuries only.
Thank you so much, sir. And I think we'll go ahead with question and answer session. Sanjay, sir.
Yes. Go ahead.
Ji, sir. Thank you so much, sir, for the comprehensive talk. And I've received a few questions on my WhatsApp regarding the talks of today. And I'll ask Dr. Abhishek to answer a few. So you talked about the pre-participation checkup. So what is the current scenario of this checkup in India, and what do you recommend that should be doable? And
see, the thing is, actually, as of now, we don't have any specific protocol which we follow in India. So there's a specific prescribed format, which is there in the Western world. Even in Asian countries like China and Japan, South Korea, they have this form, like wherever a kid is there in a school or wherever he is participating in the sports, so they have to go through everything. Like they'll get their every system checked up, cardiovascular, abdominal. They'll go through if they have any other differences in the antiversion, the whole mechanics, the alignment, they'll get everything checked. So I think as of now, in Indian scenario, I think it's high time that we, as a big nation, we should come up with something, a format which I think should be applied right from the school level, before the kid goes into playing at a high level.
Yeah, sure. We are looking to you to make some guidelines for us.
Yeah. Sure.
Yeah, thank you. So one more question: what should be the stretching or cool down routine which we should recommend?
Now, the thing is, it depends upon which sport the person is playing, which sports. So ideally, whenever we are playing a sport, the thing is, stretching forms a very integral part. So before they go into their session of training, they have to they have to do almost, if there's an hour of session, almost half an hour of stretching has to be done before, and half an hour of stretching should be done after their session.
Sure. Thank you so much. And I would like to go ahead to Dr. Raman, sir. Sir, you have told physial sparing techniques for ACL reconstruction. So as pediatric orthopedicians, first thing comes up with physis is the effect of tunneling on the physis. And is it possible that we do ACL reconstruction on one side and do a growth modulation on the other side? Just a personal question.
I think, so that is for deformity. The standard practice, people do it for deformity, but usually for pediatric ACL, because most of these children or adolescents are of they are very active age group. So I think the best way is that you should not damage the physis either of the same or the contralateral side. So it's a physial sparing surgery is the gold standard nowadays we practice. Either you go for a physial sparing or ask the patient to have limitation in activity and plan for your ACL reconstruction after 15 or 16 years. There you can go for a normal ACL reconstruction like you do it in adult.
Sure. Thank you so much, sir. And one more question, sir. When a child comes with a history of injury to knee, and I don't think many of us will be able to do a physial sparing, so we need to refer it to a regular, maybe more expert scopy surgeon. So what should be the timing of referring the child? I mean, acutely child has come with a knee injury.
So this treatment protocol is like same. It's like RICE treatment with a rest, immobilization, hold compression, you can go, and compression. That is important. So keep the knee in rest. If there is a huge hematoma, you can aspirate also. And you can ideally, the best time to repair them, go for reconstruction is 3 to 4 weeks when your knee is silent. Except for aversion injuries. Whenever you are getting with a ACL or a PCL aversion injuries, in those cases, usually we try to fix them within 7 or 10 days. But for acute rupture of ACL, I think 3rd to 4th week is the ideal time when you can plan for reconstruction in the pediatric age.
Okay. Thank you.
Dr. Arun want to say something.
Yeah, Dr. Suresh, this common misconception amongst the orthopedic surgeon is that in pediatric injuries, they all will heal. And at times the patient is also asymptomatic because he is not able to explain you the symptoms of the ACL injury itself. So if it's an isolated ACL injury, it's like a prophylactic injury for that particular knee, because sudden feeling of give way can lead to tears of meniscus, and that is like a suicide for that particular knee. So the orthopedic surgeon, whether he's a general orthopedic surgeon or a pediatric orthopedic surgeon, has to forewarn the parents that if he wants to pursue a sporting career or something like that, he need to see a knee specialist or an arthroscopy specialist at the earliest.
Yeah. Sure, sir. Thank you so much, sir. And next question
Arun, is it? Can I ask? Arun, is it that if only he's pursuing this athletic career, then only he should go? I think it should be operated, because in young age you have. How long they can continue without damaging their meniscus, they will lead to arthritis, I think. So what's the experience you people have with that?
So we can delay the surgery when the patient reaches it's about to reach his skeletal maturity. So we can do a normal ACL reconstruction in that particular patient. And if the patient is on the sporting side, we have to go for a physical sparing technique. That is why we can delay for it. So ACL, there are very less examples of isolated ACL injury performing at a very high normal sort of rate in sporting or otherwise normal life. But we have to tell them that this is like a prophylactic injury. Many isolated ACL injured patients, children or adults, they are at times asymptomatic, but on clinical examination, the Latchman is positive, the pivot shift is positive. Probably they have not tested their knee in pivoting sort of sport or daily activities of living. So if the child is young, as Dr. Rajeev Raman has given a flow chart, we can ask them, he is not into very active sports till he is about 15, 16, nearing his skeletal maturity, then he can undergo a proper ACL reconstruction. If he is in active sports at that particular time and wants to pursue his career in his sports, then physical sparing technique is the answer to it.
I think, Dhawan sir, it was a very good question. Whenever you are dealing with a children who is asymptomatic, but your Latchman is positive, you think pivot is also positive, all your clinical signs are positive. The patient is not telling any symptoms of instability, neither is complaining of any giving way in the knee. I think those are the ideal patients, non-sports person children, where you can wait till the physis close and you can plan for your normal ACL reconstruction. I think physical sparing is for symptomatic patients and athletic group. In adult, you divide it as patients who are sedentary and active. In children, you can't divide that this child will be sedentary or something. 8 years child, he will be active child. So if he is symptomatic, I think you have to plan something for him. Either if you are not doing a physical sparing, which is a very technical demanding surgery, because you have to make your tunnel under CM guide. Normal ACL reconstruction took 30 minutes. But believe me, Dr. Arun is here. If you are doing a physical sparing ACL, it takes around 1 hour to 1.5 hours, because you are passing your Bipin and the CM guidance. Every time you have to see on the CM whether you are avoiding a physis or not. So it's a very technically demanding surgery. So if you can't do a physical sparing surgery, I think you can plan for extraarticular procedure also, which has been the treatment of choice in those children for decades.
But the important thing is to counsel the parents. The most important thing that this particular child will definitely need a surgery if he wants to pursue an active sporting career.
Thank you so much, sir. One more question for Dr. Arun.
Is there any way to assess the partial ACL tear? Most of the time you get an MRI, this tear, partial tear, but it is actually a full tear. Is there some clinical science which you people are following, or you are just relying on the MRI?
Clinically, it's very difficult to differentiate between a partial and complete tear. One good sign is that if your patient is symptomatic and you are getting an endpoint which is hard, anterior translation with a hard endpoint, it is suggestive of a partial tear. Anterior end translation with a soft endpoint is suggestive of your complete ACL tear. So I think that is the only finding, where a symptomatic patient, you are having a hard endpoint, but increased anterior translation compared to the normal side. You can tell clinically, yes, this patient may have a partial ACL. Again, for partial and complete ACL, I think reading of the bundles of partial tear and complete tear, you should have a very good musculoskeletal radiologist. So ask your radiologist friend to take an MRI 15-degree oblique sagittal cut, which is very important. That is the cut which will show you both of the bundles, or if it is a partial tear, you can tell, yes, this patient is having partial tear. Because normal sagittal cut, in most of this MRI finding, you will see the radiologist is reporting a partial ACL tear, because you can't see whole of the ACL profile in normal sagittal cut. It should be 15-degree oblique sagittal cut.
So, sir, the most common mistake done by most of the radiologists is they seldom take, or they are not in control of the radiology technician. They seldom take a coronal oblique, as mentioned by Dr. Rajeev Raman. So good coronal oblique sections can easily identify a partial or complete tear. So if there is doubt, we can ask the patient to undergo a MRI again at a good radiology center, okay, and they can take a coronal oblique cuts, and that will clear our doubts.
There's one more thing I would like to say. Like in clinic, if we see the pivot shift, it is grade 2, 3, and the anterior draw is +1. So I think that goes more in the favor of surgery, because it's the more of the pivoting activity, which we need. So if the patient is pivot shift is grade 2, 3, I think that is more in the favor of surgery.
Yeah. Those are symptomatic patients.
Symptomatic patients.
Because that is what, like, if we have a partial tear, and we have a pivot shift 2, 3, and anterior draw is, or Lachman is grade 1. So I think that goes more in the favor of surgery than conservative.
So if pivot shift is positive in your hand,
yes,
that itself is a
yes,
prime indication for surgery.
Yes. So many times we have a pivot shift and we don't have anterior draw. So in that case, I think it's better to go for surgery.
Yeah. Thank you so much. One last question to Dr. Arun, sir. We have clarified. Sure, sir.
Dr. Shinde has asked a question, maybe from Rajeev.
Yeah.
You have to,
yes, sir. The minimum.
So
He has asked that.
Minimum amount of soft tissue graft in Tanner 1 and 2 cases we accept. And normally, what happens in physial sparing, it's a minimum 15 millimeter graft should be inside the tunnel. That is standard practice we follow in arthroscopic practice. So if your 15 millimeter graft is inside, because your graft heals at aperture, it's not the tunnel healing which is important, but at least 15 millimeter graft should be there in femoral tunnel.
Thickness also, like 7 millimeter is okay for children.
Yeah.
Yes. Thank you so much, sir. One last question to Dr. Arun, sir. Sir, apart from the usual RICE as first aid for stress fracture, what kind of splintage or slab or plaster is recommended, and for how long? Because it will be difficult to give a running child too much of plastering or immobilization.
Yes, so depending on the personality of the child, I usually ask the parents कि भाई बच्चा कितना compliant है, मतलब how compliant the child is, आज्ञाकारी है कि नहीं. So suppose the child is compliant and hails from a rural background, they are more compliant patient to their parents. Then at times a simple splintage like a crepe bandage and few warning tips and limitation of activity will work for around 4 weeks. Because the kid bone will heal very fast. And if the child is not compliant, you can notice in your clinic that it is still with the injury roaming around, touching your object, touching your hammer, your stethoscope, and other thing. That makes the sense that he is a bit naughty kid. And then I go for a immobilization like a fiber cast slab or something for 4 to 6 weeks, depending on the nature of fracture.
Yeah. Thank you so much, sir. And with this, I think we should conclude the question and answer session.
Thickness of graft, I think it should be 6.5 to 7.5. That is standard thickness of graft. Dr. Gopal Shinde has asked. So 6.5 to 7.5 is the standard thickness we prefer in pediatric as well.
Yes, sir. Yeah. So thank you so much, sir. And with this, we conclude the question and answer session. Now, I would like to request Dr. Vikas Sharma. He is Associate Professor in Department of Pediatric Orthopedics, KGMU, to present closing remarks for today's session and vote of thanks to the team for today's webinar. Dr. Vikas, sir, please.
Thanks, Suresh. It was a very well organized webinar. All the presentations were very precise, crisp, and academically excellent. Dr. Abhishek Saini spoke on the epidemiology and approach to pediatric sports injuries. He underlined the importance of exercise in children and the benefits of physical activity in youth. He stressed on the differences between pediatric and adult sports injury epidemiology. Another important point he stressed was that these injuries are preventable and a multidisciplinary approach is needed to manage these injuries. Dr. Arun Gupta spoke on the topic stress fractures, aversions, tendinopathies, and strains in teenagers. An important point he made out was that these injuries may be missed out in the X-rays initially, and later on they are more liable to be confused with neoplasm, This is a very confusing thing that all of us should be aware of. Then he described the pathophysiology, epidemiology, risk factors, salient points in history to make a diagnosis of such injuries, the approach to investigate these injuries, the treatment, the activity modification and rehabilitation required for these injuries. Dr. Rajeev Raman spoke on the topic of ACL injuries in pediatric knees. He outlined the differences between ACL injuries in children and adolescents versus adults, the treatment options available, the approach to decide on operative priming, whether early or delayed. Then he described the importance of choosing the physial sparing technique and the importance of rehabilitation and choosing the right muscles to strengthen. I take this opportunity to express our heartfelt thanks to the Honorable Vice-Chancellor, General Bipin Puri, for allowing us to hold this academic event. I thank Professor Ajay Singh Sir, HOD of Pediatric Orthopedics, who has guided us in this venture. I thank Dr. Faisal and Dr. Suresh, whose efforts made this webinar possible. I express thanks to UPOA, our collaborators, for this academic event. A special thanks to Dr. Sanjay, Dhawan and Dr. Anup Agarwal for encouraging us with their presence. I thank all the speakers who found time from their busy schedules to participate in this event. I thank Dr. Niraj Bijlani and Dr. Ashok Shyam of OrthoTV, Mr. Sutirtho of J&J, and Mr. Farhan of IT Cell of KGMU, without whom this event would not have been possible. In the last but not the least, I express my thanks to the delegates who attended the webinar, for it is their participation which encourages us to hold such academic events. Thank you.
Suresh, ask everybody to switch on the video so that we can take a group. Faisal, you take a group photograph of everyone.
Right, sir.
Requesting everyone to please switch on the front camera so that we can take a webinar selfie.
Janmada, welcome.
Thank you very much, everyone. It was very, very nice webinar. Very nice, very informative. Thank you, everyone.
Thank you so much.
Thank you, sir.
Good night, everyone. Thank you.
Thank you so much.
Sir.
Good night.
Bye.